Hello, everyone. My name is Durga Mithraprabhu, and I'm a research fellow at the Australian Centre for Blood Diseases based in Alfred Hospital and Monash University in Melbourne, Australia. Today, I'm going to be giving you a brief overview of the study we presented at ASCO this year. We investigated circulating tumor DNA from peripheral blood plasma and looked for mutations in the peripheral blood plasma and associated it with relapse in patients that were refractory to first-line therapy and were due to receive secondary salvage therapy. So the setting of the study was from an Australasian Leukemia and Lymphoma Group MM17 trial. So this is a phase 2 multicenter single-arm study of carfilzomib, thalidomide, and dexamethasone, referred to as ctD here, in 50 newly diagnosed transplant-eligible myeloma patients. So these patients were refractory or registered suboptimal response to bortezomib, cyclophosphamide, and dexamethasone, referred to as BCD here. And this was the frontline therapy standard of care that they received here in Australia. The methodology we employed was that we collected blood from these patients at several time points during the study. So specifically baseline at cycle 3, day 1 of therapy, and at relapse. From this peripheral blood, we isolated circulating cell-free DNA, and this cell-free DNA was then subject to sequencing for specific genes, and these were 22 myeloma relevant genes. And we looked for any mutations in these genes in specific patients. So one of the first things we did was to analyze baseline cell-free DNA, and we were able to identify mutations in baseline cell-free DNA, and we then correlated it to the response the patient had to first-line therapy, that is a response to VCD. There were two types of response, as I mentioned earlier in the setting of the study. They had either a suboptimal response or were refractory to frontline therapy. And when we analyzed the mutations, we found that patients who were refractory to VCD had a significantly higher proportion of mutations in genes that were part of the DNA repair genes pathway, which is ATM, ATR, and TP53, or part of the RAS-RAF pathway, which were KRAS, NRAS, and BRAF. And this was a significantly different proportion to that of patients who registered a suboptimal response. We then correlated the mutations to the ISS stage of the patients, and we found that patients who were classified as stage 2 or 3 had a significantly higher proportion of mutations in ATM, ATR, TP53, and RAS and RAF pathway. We then correlated this to survival and identified that any patients who were classified as ISS stage 2 and 3 and were positive for ctDNA, so they had a presence of mutations in the RAS-RAF or ATM, ATR, TP53, had a significantly shorter progression-free survival compared to patients who were ctDNA negative, irrespective of whether they were ISS stage 2 and 3 or ISS stage 1. We then looked at the mutations and correlated to relapse in secondary KTD therapy. And again, as in the case of response to VCD, we found that the proportion of mutations in ATM, ATR, TP53 and RAS-RAF, shown in the blue here, was significantly higher in patients that relapsed on the secondary salvage therapy compared to patients who did not. Again, correlation to survival indicated that any patients that were positive for RAS-RAF or ATM, ATR, TP53 mutations had a significantly shorter survival on KTD therapy compared to patients who did not have these mutations. We then went on to look at kinetics of the mutations at several time points during therapy. So at baseline, at cycle 3, day 1, and relapse, to understand how the mutations change with therapy. Of the 50 patients enrolled in the MM17 trial, 19 patients relapsed, and of those, we were able to analyze mutations from 16 of those patients. And I will show you representative examples of 3 patients in this slide. What we were able to discover was that the dominant mutations at relapse, so for example, BRAF and KRAS mutations in patient 2, ATM and RB1 patient mutations in patient 5, and NRAS and DIS3 mutations in patient 40. So all of these mutations at relapse that were dominant were already present at start of therapy. So they were already present at baseline. So to conclude, I want to finish off by saying that ctDNA mutations, or the presence of it specifically in ATM, ATR, TP53, or RAS and RAF, could be prognostic biomarkers of response, and we correlated this to both frontline therapy and secondary salvage therapy. Dominant mutations that were present at relapse in patients who did not respond to secondary salvage therapy were already present at the start of the therapy. So these 2 conclusions actually provide us the opportunity to design targeted clinical trials that might include inhibitors to RAS and RAF pathway or DNA repair gene modulators as part of secondary salvage therapies based on the presence of these specific mutations in the patients. And I want to finish this off by thanking the myeloma research group, the clinical team, and the myeloma patients. Professor Brian Dury from the International Myeloma Foundation, and obviously funding from the Black Swan Research Initiative, James and Elsie Borman Estate, and the NHMRC for making this study possible. Thank you for your time.